Okay. This is about pathology of inflammatory diseases, which common inflammatory diseases which are encountered in the intestines. So, inshallah, after this session, you guys can able to list the causes and describe the morphology of acute appendicitis, which is one of the most commonest inflammatory disease of the intestines. And inshallah, after that, if you can able to describe and list the causes of acute appendicitis, then you can able to diagnose and manage the patient with acute abdomen. Acute abdomen means severe acute abdominal pain. And you can explain the pathogenesis of inflammatory bowel disease. Pathogenesis of inflammatory bowel disease, and you can analyze the morphological and clinicopathological features of inflammatory bowel disease. Differentiate between the Crohn's disease and ulcerative colitis. You can differentiate between the Crohn's disease and ulcerative colitis. Now, the first thing which I'm going to discuss is called sigmoid diverticulitis. Sigmoid diverticulitis. First of all, you should know about what is diverticulum. So, diverticulum is nothing but it's an outpouching of mucosa into the muscularis propria, which means the mucosa entering into the muscularis propria. It dips into the muscularis propria. It may be due to some congenital defect. It may be due to some congenital defect. This kind of diverticulum, this kind of pouch, that is mucosa entering into the, see the mucosa entering into the muscularis. This is muscularis. This is muscularis propria, and the mucosa enters into the muscularis propria. So this kind of pouching can be seen even in the ileal region. It is called Meckel's diverticulum. It can be seen in the pharyngoesophageal region. It is called Zenker's diverticulum. If you know these two diverticulums enough, and in sigmoid colon also you will get this diverticulum because of intraluminal pressure. Because of intraluminal pressure. That is, for example, if the person is having constipation, okay, constipation means the stool becomes very hard. So if there is constipation, that creates luminal pressure. That creates luminal pressure. So this diverticulum happens. This diverticulum happens. So increased intraluminal pressure, and also the intestine, especially the colon, if you see, there is some weakness in the muscular layer. There is weakness in the muscular layer because external layer is divided into three parts. It is called tinea coli. It is called tinea coli, and it is surrounded by a fat tissue. It is surrounded by the fat tissue. It is called epiploic appendices. Epiploic appendices. Okay, if you go to anatomy, if you ask them, they will show you. It is epiploic appendices. So this is characteristically to identify the colon. You can see that. Okay, they have a castration and the epiploic appendices and the tinea coli. This is the characteristic feature of anatomical feature of colon. So now what happens is, because of this, the wall of the colon is weak. So any intraluminal pressure happens, easily the mucosa enters into the muscularis layer. Easily the mucosa enters into the muscularis layer. So, and if the person is taking very low fiber diet, because high fiber diet is good, high fiber diet, high protein diet will not cause constipation. Will not cause constipation. If the person is taking low fiber diet, high fat diet, it will cause constipation. So these are the reasons for diverticulum. And if the diverticulum goes for infection, and then it will comes to diverticulitis. It will come to diverticulitis, and it will produce severe intermittent cramping pain. Cramping means like muscle will stitch and release. So it is like a severe cramping pain, and continuous abdominal discomfort, constipation, and followed by diarrhea. So these are the problems of the sigmoid diverticulitis. And most important complication is, if the now the mucosa is nearly entered into the muscularis, okay, then it has to go to the serosa, okay, then it will perforate. So if the inflammation is severe, perforation can happen, that will lead to severe peritonitis. So this is about sigmoid diverticulitis. Remember, first you should know what is diverticulum. Then if it comes in the sigmoid, it is called sigmoid diverticulum. It happens due to intraluminal pressure, and because you know the colon has a weak areas, so in that area the mucosa enters into the muscularis layer, and if it goes for inflammation, it is called diverticulitis. Now, so now coming to the inflammatory bowel disease, it is a chronic inflammatory condition. It is a chronic inflammatory condition, and it is due to inappropriate immune response. It is due to inappropriate immune response, and there are two diseases in inflammatory bowel disease. One is Crohn disease, other one is ulcerative colitis. Other one is ulcerative colitis. Crohn disease seen in the ileum. Commonly it affects the ileum, and it can involve any area of the colon, but actually most commonly it is involved the small intestine. It involves the small intestine, that is the ileum. Ileal involvement is very common in the Crohn disease. And ulcerative colitis involves the rectum and colon. It involves the rectum and colon. And remember, Crohn disease will produce transmural inflammation. It will produce transmural inflammation. All the walls of the, all the layers of the intestine will go for inflammation. And here the inflammation is restricted to mucus and submucosa. It is restricted to mucus and submucosa. Females are affected more, and it is very common in the industrialized and developed countries. It's very common in US and the Western countries. Now it is coming in the Middle East as well as in the South Asian countries. It is coming more. Now people are telling hypothesis that it is due to improved food storage and decreased contamination. Decreased contamination. Actually, it looks good for us. We have less contaminated food. What happens is our immune system is made for to kill the any contaminated food if enters the GIT. If enters the GIT. What happens if the person is not taking any contaminated food? The immune system goes for inappropriate reaction. Inappropriate reaction. So this theory is called hygiene hypothesis. It is called hygiene hypothesis. Remember, actually it happens due to these four reactions. One is abnormal host interaction. Okay, these are the genes involved, and intestinal epithelial dysfunction, and aberrant mucosal immune response. Aberrant means abnormal mucosal immune response, because in the mucosa we have lymphoid tissue. Mucosa we have lymphoid tissue that will go for abnormal responses, and the microbiota, that is the microbial content of the colon, will the inflammation goes towards the normal microbial flora. Okay, so actually normally our immune system will not attack the normal microbial flora. In this condition they will start reacting towards the normal microbial flora. So here you have to understand that in Crohn's disease, the Th1 and Th17 cells are involved. It will produce granulomatous inflammation. It will produce granulomatous inflammation. Whereas in ulcerative colitis, they will not produce granuloma. They will not produce granuloma. So in the Crohn's disease, they will produce granulomatous inflammation because the cell involved is Th1 and Th17. Now coming to the difference between Crohn's disease and ulcerative colitis, and remember Crohn's disease, I said it starts from the ileal region. It starts from the ileal region, then it can involve the cecal region. Most commonly it involves the ileal region, and if it involves other parts of the colon, other parts of the large intestine, it will not be continuous. It will not be continuous. It will have some normal area. These are the normal area. This is the affected area. So it is called skip lesions. It is called skip lesions. So there will be affected area followed by a huge area of normal colon or normal intestine, then again affected area. So that's why it is difficult to identify the affected area in the Crohn's disease. Now, if it is a ulcerative colitis, if you see it's commonly the rectum is involved, then sigmoid colon is involved. It will be diffuse. It will be diffuse. Okay, the continuous involvement of the segment will be there. Continuous involvement of the segment will be there. And I said in Crohn disease they produce transmural inflammation. They will produce transmural inflammation. The transmural inflammation, that is the complete wall of the intestine will go for inflammation. So they produce the ulcer like a knife-like cut. They produce ulcer like a, it looks like a knife cut. It looks like a knife cut. Whereas in ulcerative colitis, the inflammation is at the mucosa and submucosa. Mucosa and submucosa. So the ulcer will be removing the mucosa and submucosa. It will be broad-based ulcer. Understand? It will be a broad-based ulcer. The ulcer will not be very deep. Ulcer will not be very deep. So it will be like a broad ulcer, but inflammation will be seen in the mucosa and submucosa. So since it is a transmural inflammation and it is a granulomatous inflammation, it produces fibrosis. It produces fibrosis. Fibrosis is very rarely seen in ulcerative colitis. Fibrosis is very rarely seen in ulcerative colitis. And remember, these are the major differences between the Crohn's disease and the ulcerative colitis. Now let us see the gross morphology. See, because of fibrosis, they form stricture. Stricture means constricting the intestine, constricting the lumen. Okay, because of fibrosis. So stricture is very commonly seen in the Crohn's disease. Stricture is very commonly seen in the Crohn's disease. And if you see here, this is about knife-like ulcer. Okay, if you carefully see, the ulcers are like a knife cut, very thin ulcer, and it will be very deep. It will be very deep. So, and this is a concept called creeping fat. Since the ulcer is deep, okay, it is involving all the layer. Inflammation is involving all the layer. So the surrounding fat will give you a protection. Surrounding fat will give you a protection. It goes over the intestine. It goes over the intestine. So that is called creeping fat. That is called, yeah, it will move towards the intestine lumen. Okay, it will cover the serosa of the intestine outward. Okay, so it is called creeping fat. It is called creeping fat. It is called creeping fat. This is characteristically seen. It can be seen in ulcerative colitis also, but it is more commonly seen in the Crohn disease. Now I said it produces caseating granuloma, non-caseating granuloma. Sorry, it produces non-caseating granuloma, and it is a difference between tuberculosis and the Crohn's disease. Okay, even in the ileum you get tuberculosis infection. In tuberculosis it produces caseating granuloma. In Crohn's disease it will produce non-caseating granuloma. So non-caseating granuloma will be involving all the transmural. It will be involving all the layer of the intestine. It will be involving all the layer of the intestine. You can see the small granulomas. Okay, it is involving all the layer of the intestine. So this is the characteristic feature of the Crohn's disease, and clinically it produces intermittent attack like mild diarrhea, fever and abdominal pain. It may mimic like acute appendicitis. It looks like a acute appendicitis. If colon is affected, they will produce iron deficiency anemia. They will produce iron deficiency anemia. Because the ileum is affected, it will produce vitamin B12 deficiency. It will produce vitamin B12 deficiency, and extraintestinal manifestations. You should know all these extraintestinal manifestations. And uveitis means there is a uvea in the uvea will go for inflammation. We don't know exactly why it is happening. Okay, in Crohn's disease there will be associated inflammation in other organs. There will be associated inflammation in other organs. So that is called extraintestinal manifestations. Extraintestinal manifestations. It can affect the joints, polyarthritis. It can affect the sacral bone. It is called sacroiliitis. It can affect the cervical bone, vertebrae. It is called spondylitis, and it can produce nodules in the skin. It is called erythema nodosum, and it can cause clubbing of the finger, clubbing in the fingertips. So these are the extraintestinal manifestation of Crohn's disease. I separated this extraintestinal manifestation. It is very, very important. Even though it can be seen in Crohn's disease, it is very commonly seen in ulcerative colitis. It is very commonly seen in ulcerative colitis. It is nothing but inflammation of the bile duct. Inflammation of the bile duct, and the bile duct will go for fibrosis. The bile duct will go for fibrosis. It is called primary sclerosing cholangitis. Primary sclerosing cholangitis. For example, if the person is having ulcerative colitis, and after a period of time he will develop jaundice. He will develop jaundice, and it is of mostly it will be of obstructive type. Obstructive type. So it is immediately you should think that the person is having primary sclerosing cholangitis. This is why it is very important. If the person is having ulcerative colitis and he is developed primary sclerosing cholangitis, then he has a high chance to become carcinoma, adenocarcinoma of the colon. He has a high chance to become adenocarcinoma of the colon. So that's why it is very important clinically. Now coming to the ulcerative colitis, and remember ulcerative colitis, especially in the colon. See, you are not seeing any mucosal fold here. See, completely the mucosa submucosa is ulcerated. Completely the mucosa and submucosa is ulcerated. That is the characteristic feature of ulcerative colitis, and it will be diffuse lesion. It will be diffuse lesion. So in this picture you can see the ulceration here and normal colon here, normal colon here. So colon means you see the fold, mucosal folds, but here you are not seeing mucosal fold, a reddish ulcerative lesion. So this is the characteristic feature of ulcerative colitis. And remember, this ulcerative colitis commonly after a period of time like 8 to 10 years or 15 years it will transform into adenocarcinoma. It will transform into adenocarcinoma. So if you see the whole section of the wall of the colon, you will be seeing inflammation only here in the mucosa and the submucosa. Okay, so you will not see the inflammation in the muscularis. That is another characteristic feature. And you will not see granulomas. You will not see granulomas. Granulomas is seen in the Crohn disease. Seen in the Crohn disease. Now, clinically it is different. Okay, so there they will not produce bloody diarrhea. Okay, in Crohn disease they will not produce bloody diarrhea. Here they produce bloody diarrhea with full of mucoid material, mucus, full of mucus because of complete ulceration of the mucosa. Because of complete ulceration of the mucosa. And remember, some say smoking has some benefit for ulcerative colitis, but it is not accepted, and they proved that nicotine has no link with the ulcerative colitis, because some people believed that smoking gives literally protection from ulcerative colitis. Now colon is affected, it will produce iron deficiency anemia. Colon is affected, it will produce iron deficiency anemia. If the small intestine is involved, it will produce vitamin B12 deficiency. Now extraintestinal manifestation, the most important thing I already explained. This you should not forget. Primary sclerosing cholangitis. So primary sclerosing cholangitis means what? Inflammation of the bile ducts. Yeah, it leads to fibrosis, and they will develop jaundice. And that is characteristically seen in the ulcerative colitis. There is a situation where we cannot differentiate ulcerative colitis and Crohn's disease. We cannot differentiate these two conditions. So that is clinical overlap as well as histopathological overlap. We cannot able to diagnose whether it is Crohn's or ulcerative colitis. Yeah, we cannot diagnose it. Sometimes there will be overlap happens, and it is called indeterminate colitis. It is called indeterminate colitis, and there is a separate management plan for that. Okay, so there is a separate treatment for it. Now coming to the complications of ulcerative colitis, the most common complication is developing into adenocarcinoma. So actually there is a ulcerative colitis, then they go for dysplasia, then they go for carcinoma, So this is the transformation. So it who has to be, if the ulcerative colitis patient, if he is there for 8 to 10 years, the disease is there for 8 to 10 years, and he has pancolitis, all the colon is involved, and inflammation is active, and he also has primary sclerosing cholangitis. This patient should be kept under close follow-up. Because they may develop ulcerative colitis, they can develop adenocarcinoma from ulcerative colitis at any time. So you have to keep them under close follow-up. And now coming to the acute appendicitis. See, acute appendicitis, first of all, appendix is, they call it as, it's a normal true diverticulum, which means from the ileum, sorry, from the cecum, there is a outpouching happens. That outpouch will contains all the layer of the intestine, that is called appendix. That is called appendix, a small organ which comes out of the cecum, and it contains all the layer of the GI tract, all the layer of the GI tract, that is called appendix. Now and this goes for inflammation, and that is called acute appendicitis. That is called acute appendicitis. And remember, there are many diseases mimic acute appendicitis. There are many diseases which looks like a acute appendicitis, because acute appendicitis is the most commonest one. Acute appendicitis is the most commonest one. And so but there are some diseases which looks like a clinically looks like a acute appendicitis, and one is mesenteric lymphadenitis. Okay, it comes due to infection. And acute salpingitis, especially in the females. Fallopian tube goes for inflammation. Fallopian tube goes for inflammation. That is called acute salpingitis. And ectopic pregnancy. Okay, the pregnancy happens in the ovary or tube, that will produce same clinical feature like a acute appendicitis. And pain during ovulation, it is called Mittelsmur's sign. Okay, it is called Mittelsmur's sign, and it is also looks like a acute appendicitis pain. It also looks like a acute appendicitis pain. And Meckel diverticulitis, Meckel's diverticulitis, because Meckel diverticulum is formed in the ileum. Okay, so if it goes for inflammation, it is called Meckel diverticulitis. These are the condition, along with ischemic colitis. Along with ischemic colitis, these are all can mimic like a acute appendicitis. Okay, even in the acute cholecystitis, sometimes acute inflammation of the gallbladder, that also looks like a acute appendicitis. Okay, now why I am telling this is, I put only the females here. Okay, because females have fallopian tube, so and ovulation, so this all creates pain in them, so that also looks like a appendicitis, acute appendicitis. And what are the causes for acute appendicitis? Fecolith. Fecal lith means stone like fecus. Stone like fecus that goes into the appendix, it will block the appendix. That will cause acute inflammation. That will cause acute inflammation. And a tumor can block the appendix. That will cause acute inflammation, especially this worm infection. Okay, Enterobius vermicularis, which infect the appendix. Okay, which goes to the appendix, it keeps growing there. It keeps growing there. And ischemia and any stasis of mucus. Stasis of mucus will produce acute appendicitis. Okay, if you see the morphology, the complete wall, okay, the all layers of the appendix will be infiltrated with neutrophil, and there will be edema and congestion, which is a sign of acute inflammation, and if they form abscess, if the pus is formed, abscess is formed, then it is called acute suppurative appendicitis. It is called acute suppurative. Suppurative means pus formation. So acute suppurative appendicitis. And if they go for necrosis, it is called gangrenous appendicitis. Acute gangrenous appendicitis. And remember, clinically they produce periumbilical pain, the pain surrounding the umbilicus. And if you draw a line from umbilicus to anterior superior iliac spine and put a mark from 2/3 of the from the umbilicus to the anterior superior iliac spine, 2/3 distance, and from 1/3 from the anterior superior iliac spine, this point is called McBurney's point. This point is called McBurney's point. And if you press that area and if you release your finger, then the patient will have severe tenderness. That is called rebound tenderness. And that is a characteristic feature of acute appendicitis. That is called McBurney's point tenderness. point tenderness, and they produce nausea, vomiting, fever, and WBC will be elevated. WBC will be elevated in the blood. So now this is the gross morphology of acute suppurative appendicitis. What you are seeing is appendix is swollen and it is grey color. It is congested. It is congested, and if you see the layers of appendix, it will be fully infiltrated with neutrophil. It will be fully infiltrated with neutrophils. And if you see the acute gangrenous appendicitis, it goes for necrosis and it becomes blackish in appearance. It becomes black in appearance. You can see the necrotic area here. So this is the characteristic feature of acute gangrenous appendicitis. In acute suppurative appendicitis, you will not see necrosis. You will not see necrosis. So for details, more details, you can refer to the page numbers mentioned here. Okay, so this is about the acute, the inflammatory diseases of intestines.